Hi, I'm Dr. Chris Lewis, one of the chief educators here at Doctors in Training, and I want to welcome you again to another solid anatomy lecture, and this one is on the external ear and the tympanic cavity. Now, I'll be back later for some clinical correlations and an end-of-session quiz, but for now, I'm going to turn it over to the primary lecturer, Dr. John Phelan.
If you were dissecting a cadaver in conjunction with your human anatomy course, the area of the body that you are least likely to dissect is the ear. But if you were to take the time to crack open a temporal bone, you might think you discovered a tiny amusement park connected by a large fiber optic cable to a satellite dish. The bony structures that look like a roller coaster and a Ferris wheel are the vestibular and cochlear apparatus of the inner ear, which are collectively called the bony labyrinth, and which are involved in balance and hearing, respectively. The fiber optic cable is actually the three ossicles, that's Latin for small bones, of the middle ear, which are involved in sound transmission. And the satellite dish is the tympanic membrane, which separates the middle ear from the external ear. The inner, middle, and external ear are usually collectively referred to as the ear, which is the subject of this solid anatomy lecture. The Latin word for ear is auricle, which is the name given to the skin-covered cartilaginous portion of the external ear that may be seen outside of the skull and may be decorated with various piercings. This part of the ear is also sometimes called the pinna, which is Latin for feather, wing, or fin. The other part of the external ear is the external acoustic meatus, which is the canal leading into the skull from the auricle. The word auditory is sometimes substituted for acoustic in the name of this structure, and the word canal is sometimes used instead of meatus. Meatus is Latin for passage. The non-cartilaginous part of the auricle, the ear lobe, is a well-vascularized, fat-filled fold of skin. The posterior auricular artery, a branch of the external carotid artery, enters the lobe and contributes to the blood supply of the remainder of the auricle as well. Some have hypothesized, based on its vascularity, that the earlobe may be involved in keeping the auricle warm. Otherwise, the lobe does not have a known function. The function of the remaining named parts of the auricle, which are formed by the crests and troughs of the subcutaneous plate of auricular cartilage, is to collect and funnel sound waves into the external auditory canal. The ridge along the edge of the auricle is called the helix. The ridge anterior to the helix is the antihelix. Between these ridges is an indentation called the scaphoid fossa. Opposite to the helix, the pointed extension of the auricle that partially covers the external auditory meatus is the tragus. The tragus is named for the Greek word for goat because it is often covered with hairs that make it resemble a goat's beard. These hairs are not to be confused with the hair cells of the inner ear, which will be discussed later during this lecture. Inferior to the tragus, extending superior to the lobe, is the antitragus. The indentation posterior to the external auditory canal is the concha. The tiny muscles associated with the cartilage of the auricle, such as the obliquus auriculae, may be considered vestigial and largely non-functional in humans. These muscles are better developed in certain animals who can use them to alter the shape of the pinna to maximize collection of sound waves. Cutaneous innervation of the auricle is provided by the great auricular nerve from the cervical plexus and the auriculotemporal nerve from the mandibular division of the trigeminal nerve. The latter innervates the skin anterior to the external auditory meatus, while the former innervates the skin over most of the rest of the auricle and the ear lobe. The external auditory canal begins at the opening in the auricle, the porus acousticus externus, or the external acoustic foramen, and extends into the skull. The medial 2/3, which is referred to as the bony portion of the canal, is formed mostly by the tympanic portion of the temporal bone and is completed by parts of the squamous and mastoid portions of the temporal bone. The lateral third of the external auditory canal, which is referred to as the cartilaginous portion, is formed by an incomplete cylinder of cartilage that is spanned superiorly by fibrous tissue that is connected to the squamous portion of the temporal bone. The canal ends at the tympanic membrane, which separates the external ear from the middle ear, or tympanic cavity. The cartilaginous portion of the external auditory canal is lined with skin that is continuous with the skin covering the auricle. This part of the canal has subcutaneous ceruminous and sebaceous glands that produce cerumen, or earwax. Cerumen has antimicrobial activity, and its hydrophobic lipid composition helps keep water from entering the canal. The cartilaginous third of the canal also has hairs, which help prevent foreign bodies from entering the canal. The bony portion of the canal, which is lined with skin continuous with the external surface of the tympanic membrane, is devoid of hair. The tympanic membrane, colloquially referred to as the eardrum, is attached to the tympanic sulcus at the bony medial end of the external auditory canal by the annular ligament. Where the sulcus is deficient superiorly, the membrane is attached to the tympanic notch, or notch of Rivenus. The tympanic membrane separates the external acoustic meatus from the middle ear, or tympanic cavity. The tympanic membrane has 3 layers. The outer squamous epithelial layer is continuous with the skin lining the bony part of the external acoustic meatus. The inner layer is continuous with the mucosal lining of the tympanic cavity. The middle layer is fibrous and contains radial and circular fibers that give the membrane strength. The fibrous layer is missing from the superior part of the membrane, which is the part that spans the tympanic notch. This portion of the membrane is called the pars flaccida because it is weak and flaccid compared to the remainder of the membrane. The pars tensa, which is strong and tightly stretched across the tympanic sulcus. The tympanic membrane is concave externally. Its central peak is called the umbo. The tympanic membrane transmits energy from sound waves traveling through the external auditory meatus into and across the middle ear via the auditory ossicles, a series of 3 tiny bones that span the tympanic cavity. The handle of the most lateral of these bones, the malleus, is embedded in the pars tensa between the middle and inner layers of the tympanic membrane. The tip of the handle is attached to the umbo. The lateral process of the malleus at the base of the handle forms a bulge in the membrane, the malleolar prominence. Extending from this prominence are the anterior and posterior malleolar folds, which run along the border between the pars flaccida and pars tensa. When the tympanic membrane is viewed through an otoscope, the handle of the malleus appears as a white superior extension from the umbo, while the umbo is the apex of a cone of light that extends inferiorly. This cone of light is the portion of the membrane that is at a right angle to the axis of the canal and thus reflects the light of the otoscope directly backwards. The tympanic membrane receives its blood supply from branches of the maxillary and posterior auricular arteries. Its outer surface is innervated by the auriculotemporal nerve and the auricular branch of the vagus, while its internal surface is innervated by the glossopharyngeal nerve.
Okay, it's time for your clinical correlation. So in this lecture, Dr. Phelan is covering the tympanic cavity. And this area is very important to any pediatrician, internist, or family medicine physician, especially an ear, nose, and throat doctor as well. But now, one of the most common infections you'll see in primary care is otitis media. And sometimes this is referred to as a middle ear infection. Or if anyone just says ear infection in general, they're referring to otitis media most of the time. Now, we tend to see these more often in pediatric populations. So how do these patients present? Well, the first thing is that their ear is going to hurt, and this can be pretty severe. Some people will describe this as having an ice pick in their ear. Now, they may also have some URI symptoms, or upper respiratory tract infections, things simply like nasal congestion. cough, sore throat, and even a fever. And then on exam, when you're looking in there, what are you going to see? You're going to see an erythematous, or a red tympanic membrane. If you have a significant infection, you might actually see that tympanic membrane bulging towards you. You may also see a white or an amber-colored fluid behind the tympanic membrane as well. So then what causes these infections? Well, viruses can certainly do it. It's very, very common. So respiratory syncytial virus, or RSV, rhinovirus, enterovirus, and there's many other viruses as well, including influenza even. The most common bacteria include Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Now, you probably don't really need to know all these yet, but the more often you hear them, the more likely you'll be able to remember them in the future. And we also won't go too much into treatment either here, but you may want to remember that amoxicillin is the first-line treatment for otitis media that's caused by bacteria. Okay, so that's enough of me lecturing. Let's get to these questions. So first we have, what is a conductive hearing loss, and what are some of the causes? Well, this occurs when sound waves are blocked from the outer to the inner ear. So this is caused by just wax buildup, so that happens pretty commonly. An ear infection, which we just talked about, can happen. A punctured eardrum could also result in this hearing loss. And then malformation of the ossicles. So sometimes we refer to this as otosclerosis. Next, what is the difference between otitis media and otitis externa? So this can be confusing for patients and even for clinicians as well. So let's look at this, the difference between the externa and the media. So on the infection, on the externa part, this is going to be lateral to the tympanic membrane. In otitis media, it's going to be medial to the tympanic membrane. The chief complaint, discomfort with movement of the tragus, so that's going to be more in the externa. Internal ear pain, remember we talked about that ice pick to the brain type feeling, and a lot of pressure is going to be more common in the media form. For history, on the externa, you'll hear this referred to as swimmer's ear. So a lot of patients will come in, or they've just been to the pool or to the lake or whatever, and they'll come in with a lot of gunk in their ear and a lot of pain. So that's more likely to happen with externa. With interna, again, this is going to be more bacterial or viral causes, and we talked about that earlier as well. Treatment, most of the time for otitis externa, you're going to use external eardrops. So you're putting antibiotic eardrops into the ear canal itself. But for a otitis media, you're going to use more of the oral antibiotics. Sometimes you can do a watch and wait policy, and there's lots of criteria for that, which we won't go into. And then also PE tubes, and these stand for pressure equalizer tubes. So these are little tubes that they put in. It causes a little abnormal hole in the eardrum there, and it actually just equalizes that pressure. That's why we call them PE tubes. All right, so that's going to be the end of our clinical correlation. Let's get back to that lecture.
The middle ear, or tympanic cavity, is found medial to the tympanic membrane in the petrous portion of the temporal bone. The petrous portion of the temporal bone is the dense pyramidal part found between the sphenoid bone anteriorly and the occipital bone posteriorly. You may recall from the solid anatomy lecture on the skull that it is visible on the floor of the neurocranium, where its crest forms part of the border between the middle and posterior cranial fossae. Just posterior to its crest, the internal acoustic meatus opens into the petrous portion of the temporal bone at the porus acousticus internus, or internal acoustic foramen. The facial nerve, or seventh cranial nerve, and the vestibulocochlear nerve, or eighth cranial nerve, traverse the internal acoustic meatus. The function of the air-filled tympanic cavity is to transmit the energy of sound waves contacting the surface of the tympanic membrane to the fluid within the labyrinth of the inner ear. It does so via the three auditory ossicles spanning the cavity, which are the malleus, the incus, and the stapes. The cavity is lined by mucosa which covers these three bones. More details on the ossicles will be given shortly. The tympanic cavity is usually described as having 6 walls. The lateral wall, also called the membranous wall, is formed mainly by the tympanic membrane and the rim of bone to which it is attached. Superior to the tympanic notch is the bony lateral wall of the attic-like superior extension of the cavity, the epitympanic recess. The head of the malleus, whose handle is embedded in the membrane, extends superiorly into the epitympanic recess. The roof of the cavity, or tegmental wall, is formed by the tegmen tympani, which is the thin layer of bone separating the tympanic cavity from the dura mater lining the middle cranial fossa on the floor of the neurocranium. The posterior wall of the tympanic cavity, which is found anterior to the mastoid process of the temporal bone, is called the mastoid wall. On the superior aspect of this wall is an opening, the mastoid adytus, that leads to a chamber in the mastoid process, the mastoid antrum. The network of mastoid air cells within the mastoid process opens into the mastoid antrum. The antrum and the air cells are lined with mucosa continuous with that lining the tympanic cavity. Inferior to the mastoid adytus are ridges in the bone, or prominences, that correspond to the underlying lateral semicircular canal, which is an inner ear structure, and the canal for the facial nerve. Inferior to these prominences is the pyramidal eminence, through which passes the tendon of the stapedius muscle, which will be described shortly. The anterior wall of the tympanic cavity, or carotid wall, contributes to the carotid canal, which houses the internal carotid artery. When you hear pounding in your ears during physical exertion, it's due to the proximity of this pulsing artery to the auditory apparatus. Superior to the carotid canal is the opening of the pharyngotympanic or auditory tube, which is most often called the eustachian tube by clinicians. It runs inferiorly, anteriorly, and medially to connect the tympanic cavity to the nasopharynx, where it opens posterior to the inferior nasal concha, which is in the nasal cavity. The proximal third of the tube, which is referred to as the bony part, is composed of the squamous and petrous portions of the temporal bone. The distal 2/3 of the eustachian tube is referred to as the cartilaginous part. The cartilage of the eustachian tube does not form a complete cylinder. In cross-section, it has the shape of an upside-down J. This shape can be seen in the mucosa of the nasopharynx overlying the distal end of the eustachian tube. Here, the cartilage forms an elevation around its pharyngeal orifice called the torus tubarius. Fibrous tissue spans the edges of the cartilage to complete the tube laterally. This fibrous tissue forms what is sometimes referred to as the membranous lamina. The mucosal lining of the eustachian tube is continuous with that of the pharynx and the middle ear. This lining is covered by cilia that beat in the direction of the pharynx, driving bacteria away from the tympanic cavity to lessen the likelihood of middle ear infections. The main function of the eustachian tube is to regulate air pressure within the tympanic cavity, specifically to keep the atmospheric pressure on the lateral side of the tympanic membrane equal to the pressure within the tympanic cavity on the medial side of the membrane. If you get on an airplane that climbs tens of thousands of feet, you'll experience a decrease in atmospheric pressure. And if you remember Boyle's law, you know that means the volume of air within your tympanic cavity will increase. The resulting pressure causes the tympanic membrane to bulge laterally, resulting in pain and a reduction in the membrane's mobility, which leads to inefficient sound transmission. In order for the pressure to be reduced, the eustachian tube must open to allow air to pass from the tympanic cavity to the nasopharynx, from where it may proceed to the nasal or oral cavity and be exhaled. While the bony part of the eustachian tube is always open, the cartilaginous part is normally closed, leading us to ask, what muscle or muscles open or dilate the eustachian tube? The muscles that attach to or near the tube include the salpingopharyngeus, the levator veli palatini, and the tensor veli palatini. The salpingopharyngeus originates on the cartilaginous part of the eustachian tube and blends in with the pharyngeal constrictors. However, it is thought to be too small to have a significant effect on the eustachian tube. The levator veli palatini, which takes its origin from the petrous part of the temporal bone, passes by the eustachian tube on its way to inserting on the soft palate, but does not appear to have a firm attachment to the tube. However, some researchers believe that the levator has a role in opening the tube by pushing against its side or by rotating it when the muscle contracts. The tensor veli palatini is the primary dilator of the eustachian tube. If you've traveled by airplane, you've probably noticed that you can relieve the feeling of pressure building in your tympanic cavities as the airplane ascends by swallowing or yawning. During swallowing, the levator veli palatini is the primary elevator of the palate. This action seals off the nasopharynx to prevent food from being regurgitated into the nasal cavity. While its involvement in palatal elevation is less significant, the tensor veli palatini contracts during swallowing to assist the levator in this action. When the tensor veli palatini contracts during yawning, swallowing, or sneezing, it pulls the eustachian tube towards the palate and opens the tube. Pressure within the tympanic cavity may then equilibrate with atmospheric pressure. The tensor veli palatini is innervated by the mandibular division of the trigeminal nerve. Branches from the ascending pharyngeal and middle meningeal arteries supply the eustachian tube. It is drained by the pharyngeal and pterygoid plexus of veins, which ultimately drain into the internal jugular vein. Innervation of the mucosa around the pharyngeal orifice of the tube is provided by the maxillary division of the trigeminal nerve. The mucosa lining the cartilaginous part of the tube is innervated by the mandibular division of the trigeminal nerve, while that lining the bony part is innervated by the glossopharyngeal nerve, or more specifically, by the tympanic plexus. Superior to the bony part of the eustachian tube and forming a ridge in its roof is the canal for the tensor tympani muscle. This canal projects into the tympanic cavity as the processus cochleariformis and curves laterally to form a pulley for the tendon of the muscle. The function of the tensor tympani will be described shortly. The medial wall of the tympanic cavity, also called the labyrinthine wall, is the bony partition between the middle and inner ear. There is a convex bulge in the wall called the promontory that is formed by the base of the underlying cochlea, the spiral-shaped portion of the bony labyrinth that houses the organ of hearing. Superior to the promontory is a ridge corresponding to the wall of the horizontal part of the canal for the facial nerve. Between this ridge and the promontory is an opening called the oval window or fenestra vestibuli, which is filled by the base of the stapes. Inferior and posterior to the promontory is another opening called the round window or fenestra cochlea, which is covered by the secondary tympanic membrane. The function of the oval and round windows will be detailed shortly. Besides air, the contents of the tympanic cavity are the three previously mentioned ossicles, 2 muscles, 2 nerves, and the blood vessels that feed the walls and contents of the cavity. The ossicles, which are, in order from lateral to medial, the malleus, the incus, and the stapes, are named by the Latin words for hammer, anvil, and stirrup, respectively. Their function is to transfer energy from sound waves impacting the tympanic membrane to the fluid filling the bony labyrinth of the inner ear. Unlike other bones, they do not have a periosteal covering, but are instead enveloped by the mucosa lining the tympanic cavity. The malleus has a head, a neck, and 3 processes. As mentioned previously, the longest of the processes, the handle, is embedded in the tympanic membrane and its tip is found at the umbo. The short lateral and anterior processes extend from the junction of the neck and the handle. The lateral process attaches to the tympanic membrane at about the junction of the pars tensa and the pars flaccida. The head of the malleus extends into the epitympanic recess where it is attached to the tegmen tympani by the superior ligament of the malleus. The head also forms the synovial incudo-malleolar joint with the body of the incus. The body of the incus gives rise to 2 processes. The short process projects towards the posterior wall of the tympanic cavity and attaches to the wall via a short ligament. The long process projects inferomedially and ends in the thin, delicate lenticular process that articulates with the round head of the stapes at the synovial incudostapedial joint. The parts of the stapes, which include a pair of crura that extend from the neck and end on the base, are arranged in the shape of a stirrup, hence its name. The base, which is sometimes called the footplate, fills the fenestra vestibuli, or oval window, and is attached to its margins by an annular ligament. The two skeletal muscles that extend into the middle ear are the tensor tympani and the stapedius. These muscles are activated reflexively in response to loud sounds to decrease the movement of the ossicles, thereby dampening sound transmission through the middle ear to prevent damage to the inner ear. When you take a neurobiology course, you'll learn that this reflex is mediated by the superior olivary nucleus in the medulla. The long, thin tensor tympani originates from the greater wing of the sphenoid and the cartilaginous and bony portions of the eustachian tube. It passes through a bony canal just superior to the bony portion of the eustachian tube, and its tendon emerges from the aforementioned processus cochleariformis. The tendon inserts on the medial side of the superior part of the handle of the malleus. When the muscle contracts, it pulls the handle medially, which tenses the tympanic membrane, hence the name tensor tympani. When the membrane is tensed, it can't move as freely, which limits movement of the ossicles. Thus, the transmission of high-intensity sound waves traveling through the external acoustic meatus and impacting the tympanic membrane is suppressed by the action of the tensor tympani. The tensor tympani is innervated by the mandibular division of the trigeminal nerve. The stapedius, which is the smallest skeletal muscle in the human body, originates on the internal walls of the pyramidal eminence on the posterior wall of the tympanic cavity. Its insertion tendon emerges from the apex of the pyramidal eminence and attaches to the posterior side of the neck of the stapes. When the stapedius contracts, it pulls the stapes away from the fenestra vestibuli, which suppresses the transmission of loud sounds to the inner ear. The stapedius is innervated by the facial nerve, or cranial nerve number 7. Also within the tympanic cavity are found the chorda tympani nerve and the tympanic plexus of nerves. As the facial nerve approaches the stylomastoid foramen while passing through the descending portion of the facial canal in the posterior wall of the tympanic cavity, it gives off the chorda tympani nerve, which travels superiorly and anteriorly through the posterior canaliculus of the chorda tympani. This canaliculus transmits the chorda tympani into the tympanic cavity near the junction of its posterior and lateral walls. The chorda tympani nerve carries preganglionic parasympathetic nerve fibers to the sublingual ganglion and taste fibers from the anterior 2/3 of the tongue, but passes through the tympanic cavity without innervating anything. The nerve runs anteriorly between the tympanic membrane and the long process of the incus, then crosses the medial side of the neck of the malleus. The chorda tympani then exits the tympanic cavity through its anterior wall via the anterior canaliculus of the chorda tympani nerve. The tympanic plexus of nerves, which covers the promontory on the medial wall of the tympanic cavity like a spider's web, is a sensory and autonomic nervous plexus made up of the tympanic branch of the glossopharyngeal nerve, which carries general sensory and parasympathetic fibers, and the caroticotympanic nerves, which carry sympathetic fibers. The tympanic nerve is the first branch of the glossopharyngeal nerve. It arises from its inferior ganglion within the jugular foramen and traverses the inferior tympanic canaliculus to enter the tympanic cavity at about the junction of its medial wall and the anterior extent of its floor. The nerve then branches, or ramifies, across the promontory. The caroticotympanic nerves arise from the sympathetic nerve plexus surrounding the internal carotid artery and pass through the anterior wall of the tympanic cavity from the carotid canal. They also branch out across the promontory to form the tympanic plexus with the branches of the tympanic nerve. The blood supply to the tympanic cavity is mainly provided by the superior, inferior, anterior, and posterior tympanic arteries. The anterior is a branch of the maxillary artery that enters the cavity through the petrotympanic fissure. The superior branches from the middle meningeal artery and enters the groove for the lesser petrosal nerve. The posterior is an indirect branch of the posterior auricular artery that enters through the posterior wall of the cavity, and the inferior branches from the ascending pharyngeal artery and enters the cavity through the floor. Additionally, the internal carotid artery delivers carodico-tympanic arteries to the cavity. Sites of venous drainage of the tympanic cavity include the superior petrosal sinus, a dural venous sinus, and the pharyngeal and pterygoid venous plexuses.
It's time for the end of session quiz. Let's get going. In what bone of the skull is the ear found? This is going to be the temporal bone. Next, why do you hear pounding in your ears during exertion? So this is going to be proximity of the internal carotid artery to the auditory apparatus. Next, what does the eustachian or auditory tube connect? And what is its purpose? So this connects the middle ear to the nasal pharynx, and this is going to regulate pressure. Next, what are the two muscles of the middle ear? Where do they insert? And what nerve innervates them? So first we have the tensor tympani muscle. That's going to be the tympanic membrane, and then it's going to innervate by the trigeminal nerve, cranial nerve 5. Stapedius muscle, that's going to be inserting at the stapes, and then the innervation is going to be the facial nerve, so cranial nerve 7. Next, what effect is brought about by the contraction of the tensor tympani muscle? So this is going to be it dampens the oscillations of the tympanic membrane. Next, what is the name given to the reflection seen on the tympanic membrane when looking at the ear through the external acoustic meatus? So this is going to be cone of light. Next, what is otitis media? We talked about this earlier. This is inflammation of the middle ear, usually due to a bacterial or a viral infection. Okay, so we're almost done. We have provided some images again for you to label. Recalling these images in a timed setting will help you perform well on the practical part of your exam. So label these images and then we'll be all finished. Thanks a lot.